rounds at the University of Colorado Hospital. It's sponsored by the Ethics Committee at the University of Colorado Hospital and the Center for Bioethics and Humanities. If you have questions or comments, please feel free to put them in the chat. I'm Jackie Glover, a philosopher ethicist and the co-director of our Ethics Consult Service here at the University of Colorado Anschutz. And next month, November 10th, we are going to leave room for you to attend the CCTSI Research Ethics Conference. It's noon to 3 o'clock, 3:30, and it's a real world ethics for artificial intelligence research, managing the issues, and it features Nicole Martinez-Martin from Stanford Center for Biomedical Ethics, and she's going to be talking in her keynote about the body of the data, equity and inclusion. So I hope you would join us next month at on November 10th. We are very fortunate to have our complex care transition team with us to help us learn and discuss ethical issues in assessing capacity for discharge. It features Emily McDonald, who is our UC Health System Guardianship social worker, with Louisa Neighbor, the social worker with the Complex Care Transition Team, and Jennifer Cloney, the nurse with the Complex Care Transition Team. So welcome, Emily, Louisa, and Jennifer.
Thank you, Jackie. Hi, everyone. So as Jackie introduced, we are part of the Complex Care Transitions team here at University of Colorado Hospital, and I have most recently transitioned to working system-wide for UC Health, but I rely heavily on Louisa and Jen just amidst the processing and case management of our various cases that we're faced with. So today we're going to talk about ethical implications of decision-making capacity, specifically for discharge planning. So the purpose and what some of the things that we're going to be talking about is defining capacity within the hospital setting, looking at some of the ethical implications that come along with capacity for discharge planning within a continuum of capacity, spectrum of decisions that individuals can make, and then a loss of patient autonomy within assessments for capacity. And so we'll talk more about that as the presentation progresses. So we also want to say that we understand capacity is formally assessed and documented by the medical team, but it's really important, especially within our role and within my role as a guardianship social worker, that we have an entire interdisciplinary understanding of capacity and the role that it plays in discharge planning. This is so imperative when we're planning for care within the hospital, trying to figure out plans for people. And so I think that understanding of capacity further informs the entirety of a discharge plan and how we're engaging with patients and families, and even how we can be creative on next steps. Finally, we're going to wrap up our presentation with some proposed solutions and elements that we're working on to improve the process of how we're moving through some of these cases related to capacity for discharge planning. So first, what is capacity? So capacity is generally defined in terms of the 4 dimensions as laid out by Grisso and Applebaum: understanding, appreciation, reasoning, and expression of choice. So there's numerous scenarios within the hospital setting in which we're discussing capacity, and that's for medical decisions, for discharge planning, appointment of a surrogate decision maker or an MDPOA. And each of these assessments need to be looked at in a different lens so that we can evaluate an individual's ability to make that specific decision. So each of, I think oftentimes within our role, we get, and then a lot of the times also within my role as a guardianship social worker, we get a lot of verbiage around, well, they don't have capacity. And that often leads me to question, like, for what? What don't they have capacity for? Or what does our engagement with the patient look like? When was the last time that capacity was assessed, and for what decision? So Obviously, there are times when folks are A&O times 1 or 2, and we can more consistently say that they don't have the ability to make many decisions, if any at all. But I think we still need to work on engaging and attempting to honor patients' ability to make decisions whenever they're able. So for our first consideration within capacity discussions around discharge planning, we're going to look at what a continuum of capacity might look like within the hospital. So when folks are coming in medically complex or medically ill and they don't have the ability to make medical decisions or any sort of decisions, but then how are we reevaluating and levels of engagement within that? So we work to move through ways to critically evaluate these types of questions, and we're going to also talk about some case examples that fit into these considerations as well. So, sorry. With the continuum of capacity, there's a lot of things that need to be considered. So people have a range of ability to answer questions, a range of questions that might be answered, or a range of questions that might be asked of them. So there needs to be continual assessment, specific documentation, specific questions, and evaluation of medical clearance. So within capacity assessments, it's really important that we are continuing to evaluate and acknowledging that this can change over time and should be continually assessed and for specific questions. So there are times when we have found ourselves really stuck on how to move forward on a discharge plan due to previous assessments around lack of capacity. But sometimes when we go back in and speak with a patient, they're presenting a lot differently than they were at the beginning of their hospitalization. So it's important to remember that presentations change throughout the hospital course for many folks. And so it's important to have continual assessment, specific documentations as to what was being assessed at that given time, and questions that we're asking when evaluating for capacity. So some of the most important considerations for a continuum include this idea of a blanket conclusion of lack of capacity. We're really trying to stray away from this. Obviously, I recognize, especially within my role, that this can happen, but we want to try and dig more deeply into what they may have capacity to do versus not do. And just because they don't have medical decision-making capacity does not automatically mean that they can't make any sort of decisions. So another consideration that we will also talk about within our case examples is we've really found that there can be varying levels of engagement with patients based on the providers that they're interacting with, and that leads to different interpretations of assessments. So this is why I think it's really important that we have an interdisciplinary focus, because rapport building, especially with some of our behavioral folks, is really important. We all have a different lens that we're bringing to the table. And so some people might not like talking to psychiatry, or some people might not like talking to the primary medical team, but how can we come together as a team to truly delve into these assessments of capacity and figure out how can we work with them within a framework that works for them. Another piece that we often talk about within, I know we've had numerous discussions with Jackie around this, is do the patients have a right to make a bad decision, or do they lack capacity? So this question comes up all the time. And I think it really warrants continual assessments to determine if they have the understanding and are consistent about why they're making the bad decision. Because as Jackie has pointed out in numerous assessments, is they have the right to make those bad decisions. And I think this really comes up a lot with folks that are readmitted. There's a lot of distress over failed attempts at discharge, and we're just doing the same thing over and over again. But at the end of the day, if they have the right to make that decision and they don't have the documented impairments that lead us to question, like, do they really understand the risks of this bad discharge plan, then we have to honor their ability to make that decision. So within that lens, I'm going to hand it over to Louisa and Jen, because we're also going to talk about that case, a case like that specifically. So where folks were admitted over a long period of time, where we really got to work through this continuum and see how it unfolded. and evaluate how we were engaging with these patients at any given time throughout their hospital course.
I'm Lisa, the social worker with the complex care team. So our first case example is related to a patient with a personality disorder and successive readmissions. Over a number of years related to failure to thrive. She was readmitting from home. Patient was consistent with a lack of insight into impairments, and on each admission, capacity assessments were variable, partly due to her level of agitation and behaviors during the time that she was in the hospital or in the emergency room. It was difficult to truly assess their capacity until they had calmed down and were able to more appropriately talk through their plan for discharge and the supports that were available. Throughout these admissions, when patient was able to more appropriately engage, there was often a final determination that patient had capacity and could return home despite concerns or recommendations for additional support. After years of this cycle, patient began to physically decline and was no longer able to discharge home despite their requests, and they could not formulate realistic plans based on the current level of functioning. This poor insight and simultaneous cognitive decline led to the assessment of lack of capacity and recommendation for guardianship and conservatorship to facilitate discharge planning. There was a lot of moral distress around this patient's prolonged hospitalization and request to return home. There was a reality that patient had been able to make bad decisions to return home without support for a long time, but with continued concerns about patient's cognitive and physical decline, it was now more ethically justified for a patient to remain in the hospital for safety and care planning, and providers could no longer state that they truly understood the risks of returning home.
Emily, could you tilt the camera towards the speaker? You.
It was often very difficult to find a final determination of lack of capacity and justifying the need for guardianship. Therefore, there needs to be many different assessments, meetings, and other discharge considerations prior to pursuing guardianship. From this case, over a number of years, all of those avenues have been explored, leading to the final determination of a need for a guardian to support the next steps. Within that, though, it was also important that we remembered to include patient in the care planning as we were able. This patient had varying levels of engagement based on the rapport that they had with specific providers and staff on our team. So whenever possible, the hope was to continue to include them in decision-making whenever possible.
Sorry, and we had another medically complex patient who lived alone with housing through the coalition. Patient had a substance use disorder and often presented to the hospital due to noncompliance with medication and follow-up care. They were readmitted on several occasions and frequently presented with limited engagement and willingness to participate in care planning. Their capacity was often in question due to this limited engagement in response to provider questions. Medically, as they continued to improve and the team would continue to work on engagement, they began to participate and they were able to identify what they wanted to do for discharge on various admissions. Through each admission, they were eventually assessed to have intact capacity despite documented moderate to severe cognitive impairments and continued concerns for safety in the community. Various discharge plans were set up for them, including subacute rehab and returning home with HCBS. The patient continued to deteriorate over time and recognized the need for additional support, although they were adamant that they would not go to long-term care. On the last admission with us, patient presentation was similar to previous admissions, but again, when they did fare medically, they were participatory in their care. This knowledge of how to engage with them and identification of their goals allowed us to assist in finding the appropriate level of care. Due to his engagement, we were able to secure an assisted living facility through their participation in the care team meetings and phone calls with the assisted living. Continuing to assess her capacity and finding various ways to engage with this patient was imperative in formulating a successful discharge plan. With our limited engagement, much of the time we were working on assumption that they did not have capacity. But through time and rapport, we were able to establish a consistent platform of communication that assisted in identifying a placement that they would be successful in.
Jen, can you just define HCBS?
Oh, home and community-based services, additional supports for the patient in the home.
Thank you.
Okay. Another consideration that we're going to talk about is the spectrum of decisions that folks can make. So there's a wide range of decisions that we are assessing for capacity for, and that's higher level decisions and lower level decisions. And so one of the lower level decisions that someone can make is the appointment of an MDPOA or someone that they can trust. And so when we're looking at the lens of discharge planning, it's often important for us to document a surrogate decision maker. And that's not even with just discharge planning, that's overall care planning within the hospital. And ideally, this is someone that a patient is able to identify that they trust. So while they might not be able to make the higher level decisions about surgery, medical treatment, and all those things, are they able to identify consistently someone that they trust within the role of the MDPOA? Are they able to understand and teach back that role as we're talking with them about it? At this time at UCH, we don't have a formalized way that we're going in and assessing for ability to make an MDPOA, but it's becoming increasingly more important that we document for individuals if we're able. And I am seeing a cultural shift that we are trying to honor the patient's choice within that. Often in our role and within our ethical discussions and framework, there are numerous discussions around discharge planning and capacity, and we ask, like, what is the level of risk for them? And so I think for the appointment of an MDPOA, it's a fairly low level decision, fairly low level risk that someone, even with cognitive impairments that are documented, is able to identify consistently. As I mentioned, we're trying to establish more concrete processes around this documentation and ensure that there's consistency that is consistently documented with the expression of choice. And sometimes I've started to see that allowing this patients to have this voice is helping us to move through various care plans for patients. So within this light of appointment of an MDPOA, even amidst other cognitive impairments or other concerns about discharge planning and how we're going to move through, I'm going to hand it back over to Louisa and Jen. They're going to talk about some of our more complicated cases that we've been able to successfully document an MDPOA.
Our first case example, patient was admitted for failure to thrive and a home medication error. There was a history of severe dementia was noted in the documentation with a limited insight into the functional deficits and had multiple documented concerns for safety despite home support. Assessed on numerous admissions to lack capacity for decision-making for medical treatment and discharge planning. Due to the assessment of the lack of capacity, a proxy was identified for discharge planning. The care team discussed the difficulty with determining next steps as patient was able to demonstrate some awareness and planning, calling their PCP, identifying that they had made a medication mistake, but consistently demonstrated poor insight and failed attempts at success in the community. Due to the level of understanding, the patient was assessed for ability to complete the MDPOA. MD assessed the patient was consistent with identification of an MDPOA, and social work was able to establish consistency the following day with the same they identified the same person. Patient expressed that they felt that they could trust this person to make decisions for them, citing, "Of course I trust them, we grew up together, we know a lot about each other." With this identification of MDPOA, the MDPOA was able to further assist with discharge planning in connection with community resources to offer more support at the time of discharge. While guardianship was discussed during this hospital setting, with the identification of an MDPOA, we were able to honor less restrictive options for patient and still create an additional layer of support for discharge planning and for success in the community.
Patient had expressive aphasia, making communication difficult. Speech had various picture boards that nursing staff utilized for care, but when discussing more in-depth conversations around medical decision-making, they were deemed not to have capacity. And therefore, a surrogate decision maker was needed. They had an MDPOA on file, but due to limited engagement from that MDPOA, a proxy was identified. During rounds, a discussion was had with the provider around patient's appropriateness to complete an MDPOA. The provider indicated that they felt patient was consistent in their choice of an MDPOA. They were able to communicate non-verbally through hand gestures and nodding yes or no. To ensure the team was understanding them correctly, assessment was completed over the course of a week with and without the presence of the medical proxy to ensure that they demonstrated consistency and understanding of the role of an MDPOA. Throughout this time, they consistently identified the medical proxy to become MDPOA and confirmed they no longer wanted the person listed on the previous MDPOA to continue to serve. While this patient was unable to demonstrate teachback of the role and purpose of an MDPOA, they were able to communicate a level of understanding about who they trusted to serve as a decision maker for them. They were consistent over time with various parties, including case management and medical providers. This was documented extensively within their chart due to the complexity of their impairments. With increased understanding of the patient's communication style, we were able to honor their expressed wishes and allow them to document who they trust to serve in their decision maker role.
And that really ties into about trying to honor a patient's autonomy. And so I'm going to talk about how sometimes capacity evals lead to a loss of patient autonomy. So discharge planning, regardless of a patient's capacity, should really focus on patients' identified goals. We often go, and especially within the hospital setting, we often go towards a recommendation of long-term care as the most ideal, most identified, safe option for folks. But we need to be also looking at the goals of the patient and what is it that they want to do. Even within guardianship, the courts require that individuals are considered and included in any and all decision-making that they are able. So even when they have a legally appointed decision maker, it cannot necessarily force decisions on patients, and therefore it's really important that we're working to align with the goals and attempt to work on discussing the recommendations and how that might best fit into their identified goals. As we kind of touched on guardianship, as we've touched on some of the lesser restrictive options, guardianship is the most restrictive option to be considered for someone. And that's taking away any sort of legal rights that they have to make decisions. And so with that, there are a lot of ethical implications that are associated with that. And there are checks and balances, obviously, within the guardianship system, but I think that's really important that we take that evaluation for ourselves as we're navigating cases and trying to figure out whether they need a guardian or not, or can we work to align with their identified goals. That takes a lot of rapport building and understanding of an individual's impairments and processing abilities, as we just talked about. So often within my role, specifically as a guardianship social worker, we can get so caught up in the medical recommendations and move through the discharge plan without including the patient in the process. So sometimes I even have to remind myself, oh wait, what does the patient want in this? And we can get so sidetracked in the movement of trying to determine what the best and safest discharge plan is for someone that we can forget to ask them that question. I think an additional consideration that often comes up within the loss of patient autonomy, and something that we've talked about within a lot of ethical discussions and moral distress discussions, is, are we doing more harm than good by patients remaining in the hospital for our, quote, safest discharge plan? So I think a lot of the time when we are questioning patient safety, and then they're expressing a lot of distress, we're trying to figure out, is it really more harmful for these people to remain in the hospital? We all know that the hospital is not the most appropriate level of care, especially when patients are medically ready for discharge. So I think we're often faced with these continued safety concerns for folks, especially when we have documented impairments. But I think ethically, we have to continually ask ourselves, what is our plan of care? And are we doing more harm than good by keeping them in here for our, quote, idealized safe discharge plan? Are there other things that we can talk about with patients and families even to consider lesser restrictive means? Having engagement with providers and therapy of what is the recommendation and how can we foster at least a semi-successful or safe enough discharge plan in the community? So I'm going to hand it back to Louisa and Jen of some examples that we have even gotten caught up in this reality of, going towards a discharge plan of long-term care and realizing that there are other options available and really trying to honor the patient's autonomy as much as possible and moving forward with care planning.
All right, and our first example is ultimately she did go to long-term care placement, but the rapport building and planning and engagement with her was a significant piece to making that successful. The patient had a history of borderline personality disorder and memory deficits. They were discharged to a long-term care facility and subsequently readmitted the next day after threatening a roommate at the facility. Due to patient's physical and cognitive impairments, they continued to require a long-term care facility, but this was difficult to facilitate due to patient's behaviors and unwillingness to discharge to a new facility. The overlay of the difficulty with roommates created further barriers to discharge, particularly with long-term care facilities, as Medicaid only pays for shared rooms at facilities. With extensive rapport building, education and engagement, social work and case management was able to work with patient on identifying a care facility that they were comfortable with and amenable to. Patient eventually discharged to the long-term care placement after meeting with staff from the facility and creating a plan that aligned with their goals and desire for quality of life. The identified goals included a private room, access to a Catholic priest and services, and a, quote, clean and nice facility. Although difficult to find initially, following identification of a facility and extensive preparation of facility and patient, they were now thriving. They are now doing very well at the facility. This documents the importance of a patient engagement and allowing for autonomy wherever possible, particularly as this facilitates a more successful discharge plan and allows for them to feel like they have a voice in the plan.
Patient presented to ED more than once for being lost and unable to find their home. Upon successive presentations, they were admitted for failure to thrive and cognitive impairment. No reversible causes of impairment were identified, and with cognitive tests completed, patient demonstrated severe cognitive impairment with an Allen level of 3.2. They were assessed to lack capacity early on in admission, and the recommended plan of care was for long-term care placement. When meeting with the patient, they were able to clearly identify that they did not want to go to a nursing facility, but identified through the process they needed additional support and were agreeable to discuss alternative options. Based on patient's presentation and benefits identified, assisted living was an appropriate level of care to explore. They were amenable to pursue this option and were able to be a part of the facility search, requesting specific locations, etc. An appropriate facility was located and patient was successfully discharged. This case highlights the importance of engagement and goal discussions with patients regardless of their capacity. We cannot force placement on individuals despite their level of capacity. And while we have referenced that it is often a continuum, it is important that we continue to have patients involved in discharge discussions to honor their autonomy and any decision-making that they are able to have.
And so to kind of wrap up some of the big key takeaways that we have been discussing throughout our case examples and just these considerations, I also wanted to talk about some of the pieces that we often consider within capacity assessments for discharge planning. So as I mentioned before, we can't necessarily go in and always make a blanket assessment of capacity. Obviously, when we're moving through decision-making for guardianship, that is more of a blanket, like they can't make any sort of decisions for themselves and we have to go to a guardian to make that decision. But we want to first best honor their autonomy. So I think we need to be asking how we are engaging with people. How are we asking these questions? Is it in a more structured way? Or are we having conversations around their capacity or around discharge planning, around who they trust, all of those things? I find that individuals can be far more open to having a conversation versus more of a formalized, structured assessment of question after question after question. So what circumstances brought them to the hospital? That's often a question that we evaluate and think about when we are navigating discharge plans for people, or just even care plans throughout the hospital. So I think it's a large consideration is how many times they've come into the hospital and for what reason did they present at this time. Some individuals live quite successfully in the community despite our questions as to how they're able to do it. And so I think that that's a large piece of this puzzle, is we can't, while we might have these recommendations and thoughts of how they could live more successfully, we also have to think about all the other people that are doing okay and doing fine in the community and want to go back to that level. And we need to be honoring that too. There's obviously might be a time and a place that we need to evaluate it differently, as we kind of talked about in our case examples. But I think we also need to be thinking about, was this the first time that they presented, or is this the 16th time that they've presented? To piggyback off of that, obtaining collateral information from the community is really important, from the primary care provider, home health care, family and friends. Gathering all of this information to help create a better picture of how they're doing in the community is really vital, because we have a really specific lens within the hospital setting. So it's important that we gather all the information of how they've been functioning in the community. And then another consideration, obviously, as I've mentioned, is what are the patient's goals? So I mentioned this throughout the presentation. And so we need to remember to speak and work to align with the identified goals as much as possible. What supports are available? This is a large consideration. It's amazing when people have family, because we have talked about endlessly that if you have family and supports, you are able to be successful in the community for longer than maybe some other folks that don't have the same level of support. And sometimes the other options need to be considered. And then finally, can we support a discharge plan that is, quote, safe enough? As I mentioned briefly throughout the conversation, or throughout this discussion, we need to look at the specific recommendations from the medical team, from therapy, and then also be asking, what are the patient's goals and what do they want? What are the available resources in the community? And can we work to provide a safe enough plan to support the discharge that really aligns with their goals? And then, as I mentioned at the beginning of this presentation, we're kind of working as a system on trying to standardize the way that we're looking and assessing for capacity, because these cases are so gray often. And so we are in the very early stages of a system-wide approach to a decision-making capacity agile pathway. And so some of the considerations within this would be medical decision-making, appointment of an MDPOA, discharge planning. And so we're hoping that with this pathway, it will allow patients, families, and providers to have a better understanding of how we move through some of these cases that we're often faced with. When we know that they have impairments, but want to be really meaningful and mindful about how we're best supporting them and figuring out a discharge plan. A multidisciplinary approach, I think, is really important. The goal is that we create a better multidisciplinary approach to a capacity evaluation. So there's a lot of moral distress that often surfaces from these complicated cases around capacity questions and individuals remaining in the hospital for a prolonged stay, especially when they're medically ready. So I think it's imperative that we're coming together as a team to really be creative on care plans, not only within the hospital, but outside the hospital as well. So questions like, while I get this as the recommendation, what are some of the other ways that we can look at discharge planning within their identified goals to foster their success? And then lastly, it's really important how we're engaging with patients and families. So I think the engagement with families is really huge if they're around, so that we can really utilize them as a support network for not only the hospital, but the community as well. Families' own understanding of the thought processes and the reasoning behind the recommended discharge plans and possible solutions for that. So I recognize there's a lot that comes up with this topic, and we're only touching on like a little bit of it, especially within our lens of discharge planning, but these are just some of the considerations that we have started to capitalize on within our system work to figure out how are we engaging with providers in the multidisciplinary team around capacity assessments for discharge planning.
Emily, thank you very much. There's several questions about, do you have an assessment tool, a form in Epic? Can you please speak to the existence of such a form for decision capacity of medical interventions, and what led you to try to expand on that form?
Yes, so right now we have a DOT decision, which is a great tool for the assessment of medical decision making, but it is really catered to medical decisions and treatment planning for those medical decisions. And so, as I talked about within the standardization of this decision making capacity pathway, I have been working with hospitalists, psychiatrists, and the system to try and formalize a way that we are also capturing decisions for discharge planning and how we're moving through that assessment and what does that look like and what questions are we trying to target. So there is not a formalized way that we're doing that right now, but that is in the works.
And the chat was alive with a great point about our language of bad decisions. Maybe they're not bad decisions, they're decisions that we don't agree with.
Absolutely.
I think the team would absolutely endorse that.
Yes.
What do you say to the team? I know this is a conversation about discharge, but so often the ability, how many cares and the cooperation of the patient is key to having them discharged to the right level of care. So can you speak to the lack of capacity? You're trying to empower people and they're refusing turns, wound care, dysphagia diets that would really expedite their discharge. Can you speak to that?
I think that that's where it gets really hard, and that's the multidisciplinary approach that I'm referencing. Is like those are the complicated patients, and those are the ones that we specialize in. I don't think that there is a formulated way that we're going to deal with each patient that refuses turns or doesn't want to do things, and it's each week really. I think it speaks to where we're meeting the patient and how we're engaging with the patient, that level of rapport building. There's not a blanket, oh, this is what you do, but it's getting the multidisciplinary team together to figure out what are the recommendations, what are the care needs, and then talking to the patient about, these are the care needs, what's the reasoning behind not wanting a turn? What's the reasoning behind these refusals? And then figuring out, can we create a happy medium? So maybe they don't need to be turned as much. I think that there's a lot of medical recommendations about plans that is the most ideal option for folks. And I think that that is the same with the bad decision piece. We have these recommendations and these thoughts about what would be best, but that doesn't always mean that that's what the patient wants. And that's what is absolutely 100% needed. So that's what we really try and work on too as a team.
So
Sharing your screen, Emily.
Related questions. Do you assess for financial powers of attorney, assess capacity? Because someone pointed out, in order to get Medicaid, they have to document, they need a financial power of attorney. So how do you manage the financial end of capacity in order to discharge?
Yes. It's hard, case by case basis. I can't say for each person. And that's why it's a specific assessment into, do they understand what a financial power of attorney is? Do they understand the risks and the benefits of having one? And if they're not consistent about that, then they can appoint one. But are there other creative ways that we can work to align with their goals and still get them discharged? Or do we have to move forward with conservatorship, which is the financial legal appointment of a decision maker through the state of Colorado? So it is a gray area again with financial decision making.
So this is an intriguing question to me. If you're looking in the community to really help you in your assessment, how do you handle the release of information? necessary to contact people in the community.
I mean, a lot of it falls under, well, a lot of our
Yeah.
engagement falls under continuity of care. So that's where it gets, I don't know, it's easier for us. I don't know what just happened. I like exited out.
I think we do the questions. It's presented as we have this patient in the hospital. We're trying to gather additional information. I think we're thoughtful about how far we're going into delving into their entire life in questions. We're thoughtful of this is specific to this circumstance, this hospitalization. Do we need all the layers of the onion unraveled? No. And that kind of continuum of care. If there is a sense from patient or from family that there are people maybe to not have involved, I mean, we're mindful of that. So we're careful of, even if they're diminished capacity, I always ask, can we talk to your family about kind of trying to help figure out what we're going to do next? We're not going to tell them everything that's happening play by play in the hospital, but is it okay with you if we get them involved? And so we do try to have those conversations as well with patients. This is solely just to help figure out what's happening next.
And it's a lot of our own information gathering versus providing any information
Yeah.
from our lens. It's a lot of just collateral information that we're trying to obtain.
So just as we label some decisions bad, we label some families as challenging. So how do you balance success in the home, or what families should be able to do, with actually the emotional and other toll on families? Here's the individual, and their success in the home requires the cooperation of family. And we often are judgy about that. How do we take into consideration the impact of having their loved one live in their home, even though that's what they want?
Right. Yeah, and I think that's hard because it goes into a lot of the recommendations that we have for 24/7 like supervision. And that's like so hard for any family to be able to provide. And I think that we have to figure out what works within their family system, and is that okay? I think that this comes up a lot of, again, it all loops back to what is our recommended plan and what is our perception of a bad decision versus a good decision. And yeah, no, go ahead.
And we've had this conversation recently quite a few times about also we know that they need more support. PT and OT and the physicians we can clearly see that they need more than what they had before they came to the hospital. But then getting into the nuances of what is it that they really need support with? And is that a specific thing that the spouse can identify, whoever the caregiver is can identify, I can handle this part, but I need help in this other piece of it, rather than just saying, you're going to go to long-term care because you need 24/7 because this person can't make those decisions anymore or cooperate with what's going on. And then figuring out that more nuanced piece of where is it that they need support. Because sometimes they can go home because they didn't actually have any of those additional supports in place, but not just leaping to, you don't have capacity, you have to go to long-term care. What is it in between that we're missing that people didn't know to ask for, didn't know that they could get benefits for? And that's the other piece, but that takes that time and that rapport with people of what is it that you're struggling with, and then where can we fill in gaps? So,
and I think that goes back to the piece that I was talking about with just like, how were they doing in the community before? Were they functioning well enough? Were people making it work well enough? And that's where we get lost sometimes.
So an interesting debate between a conversation about between Henry and Patty. One is that we face one question that we face all the time, the patient who simply won't engage in a conversation or a capacity assessment. And we assume they lack capacity. Why this assumption? Is that the right assumption?
I grapple with that all the time. They have heard me say that a lot. And I think that that's why I've addressed the piece about the behavioral, because I do think that the level of rapport is so important. So going in and trying to just have a casual conversation first before we're jumping into a more formalized capacity eval, and whether that means with, you know, the occupational therapist or whoever, the nurse, I don't know who it is, who they can establish more rapport with, that's only going to help us figure out for that behavioral patient that we're referencing, or the ones that don't want to engage with us, where can we align and how can we engage?
So language, going back to the bad decision language, we talk about a safe enough discharge, even though our lawyers don't want us to use enough. Sorry, Ellie. It's either safe or it's not. So we have taken a page out of your book, the VESPA book, with adults who are vulnerable. They talk about risk reduction rather than safety. They reverse it and the safe enough. What can we do for risk reduction? And that's Patty Mayer's point in the chat. Often we want the best discharge or the safest discharge, and it's not even possible. So
Right.
You guys are genius at what we can actually do.
I don't know about genius, but thank you. We just try and figure out how we're going to, I mean, even as simple as, did they have home health care before? Can we get that going for them? Did they have a meal delivery before? Can we do that now? Those types of things before jumping to a more restrictive option like long-term care. So that's what we try and do too.
And Art wants to know if there's no options. Do they just live in the hospital forever? And
No,
the answer
our
is
boss
no.
would hate us for saying that. No, we just want to be,
Never, never, never.
No.
There's always eventually
there's a
enough
plan.
conversations to figure out something.
Even
And
right
it may
now.
not have even been what any of us initially thought it was going to be. And then time goes on, and I like to say sometimes they rehab themselves a little bit, you know, and then we get to a different place and there's a different choice, you know, or a different option that they can explore. And I wanted to kind of just a little bit to what you were making a point earlier. We recently, you know, had an interesting lady that made the point that if she had not come to the hospital, we would not have had all these concerns, and she would have been in the community doing whatever it is that she would like to do. And because she came here and we said she didn't have capacity, we were taking over her life, and she resisted that from the day she got here to the day that she left. And it was a good lesson of, fair enough that if you hadn't come to our emergency room, you would be out doing whatever it is that are capable of doing.
Yeah.
And it was just an interesting perspective from her point. She would not engage in conversations with a lot of providers, but she was very clear on like, well, why do I need to talk to you about this? If I hadn't come here, you wouldn't know that any of this is going on and telling me what I can do. We're like, that's fair. So.
Right. Great question from David. How do you measure success when you do get the EPIC tool and you have change the culture so that it's multidisciplinary attention to a discharge plan? How are you going to measure success? Bounce backs, hospitalizations?
Yeah, patient adapting to their new environment.
Yeah.
And a lot of times we'll have meetings with that facility or place and just kind of help them with what we were doing here to see if it helps there, and by the patient not being readmitted and eventually becoming happy or at least satisfied with where they are.
And I do think it's a cultural shift too. I mean, like I mentioned before, but when I started working here, there was more of when they didn't have capacity, we wouldn't do any sort of appointment of an MDPOA. We didn't do any of that. So now we are shifting the culture of, you know, I have a patient right now that doesn't have capacity, but does have an MDPOA that we were able to complete. And so I think it's a lot of different ways that we can measure the success of this.
Good. Here's a really difficult question that we're just beginning to grapple with. What about the capacity of decision makers? I also am at Children's Hospital Colorado, and the parents are not our patients. We have no jurisdiction over assessing the parents' capacity, but yet it has a direct impact on the care of the child. The same in adult hospitals.
Right.
This MDPOA, they call ethics. This MDPOA it doesn't have capacity. And we're just now convening a group from psychiatry, from ethics, from legal, from our VESPA team for geriatrics to talk about assessing capacity of decision makers. If someone has a way that they already do it, we would really like to hear what you're doing.
Yeah.
We only did it once to get rid of an MDPOA, but the sister said this MDPOA is already under guardianship. So they had guardianship papers for the newly appointed MDPOA, but that's almost never the case.
Mm-hmm. And even with APS in our experience, there's not always a ton of guidance on that of lack of capacity for a decision maker. So yeah, if people have suggestions, we would love it.
Yeah, put them in the chat. What are you
Yeah,
doing?
And recently had that come up.
So we have a home care crisis, waiting lists for home care. How do you interact in the community? People, and APS is guilty of, they're safe, they're in the hospital, and we're trying to get them in the community where they want to be. What can be done about the shortage of home care?
Oh, I don't know. We have a shortage. We have a
That's
shortage of like facility staff too. It's like a shortage everywhere. So I don't have an answer.
I don't think we have an answer for
I
that.
wish I did, but I don't.
We just keep looking for an agency that would have enough hours to support this individual.
Yeah.
Who pays for assisted living? One of our participants wanted to know.
Oh, everybody.
Most common is private pay, long-term care Medicaid, and most places will pay for that at Medicaid facilities, so that changes options. And then some long-term care policies will partially pay. I don't know, I've not seen one that pays the whole thing, but they will pay part. So those are the most common I've seen. I'm sure there's other, and the VA has some assisted living type programs.
The difficulty obviously is probably doesn't come as a shock to many people is the Medicaid facilities that for ALFs are just, they have a long waiting list. So that's where it gets really challenging. Yeah.
I don't see any other questions in the chat. Okay. Oh, Katie has added Medicaid waivers for behavioral health, for instance, pays partial, but the patient has to pay a third of the rent.
Yeah. So they have to have benefits for that too.
That's true. There's always a patient portion if they have Medicaid that's paying for the facility, whether it's nursing home or assisted living. So.
Okay, here's a hard one. How do you reply to it's not a safe discharge and the fact that Medicare can and will penalize the hospital?
I guess well, we're working on the idea of formulating a safe discharge plan. I mean, whatever that looks like, I think, oh, Ellie, go.
Oh, there you go.
I like that.
Ellie is
Ellie's
an
gonna
answer.
take it away. Can you unmute Ellie? Ellie's with legal, so it's probably much more appropriate that she answer that question.
David, can you find Ellie and unmute her?
Ellie Bain.
Ellie, do you want to chat it? Yeah, you can't unmute. David is all powerful. Can you chat?
Okay, there we go. Thanks, David. So what I tell are the actual wording of the regulations and the conditions of participation is that a hospital or a provider that participates in Medicare must have a safe discharge process, right? And must identify those patients that may require additional services upon discharge, whether that's long-term care or community resources. It does not say anywhere that we have to provide a range of resources or that we have to have access to all of these things, because it's just simply impossible. I mean, obviously, Emily's team can tell you, there are patients for which we have 2 or 3 options, and then there are patients for which we have a shelter, and that is the option. So a couple things. A safe discharge means that we have really tried to do everything that we can to at least return the patient to the situation that they came from, if that situation was an environment in which they can live their life as they have chosen to live their life. So for some patients, that means returning to the streets. That's the situation that they find themselves in, and that's the decision that they've made. For some patients, that means that we need to get them off of the streets and assist them in finding another place to be. So safe also doesn't mean ideal. Again, we may want to place these patients in long-term care facilities where they can be cared for by qualified practitioners, and where we know that they have meals, and we know they have access to water, and we know they have access to shelter. And for whatever reason, that patient or their family may not want that. That patient's family may be hell-bent on returning the patient to home, even though we have serious misgivings that they might not be able to provide the care that we think the patient needs. So again, I would say, safe doesn't mean ideal. The regulations don't require us to provide ideal, but the regulations do require us to make sure that we know what that patient's goals are and what their limitations are and what resources are available to them.
Thank you, Ellie. You answered that much better than I would have.
So in summary, thank you all very much, Emily, Louisa, and Jen. In summary, do have a capacity evaluation tool in EPIC for medical interventions, but do expand on it to include a multidisciplinary team that can assess capacity for discharge. Always try to do what the patient wants, and choose the least restrictive or the discharge that aligns most with the patient's wishes. That is also doable. And lose the language of bad decisions or safe enough. You're doing risk reduction. I hope you will. Thank you very much. And I hope you'll join us November 10th for Real World Ethics for Artificial Intelligence Research, Managing the Issues, Dr. Nicole Martinez-Martin, The Body of the Data, Equity and Inclusion at noon on November 10th. This session has been recorded. It's available on the Center for Bioethics and Humanities website under Clinical Ethics, and so is the flyer for next month's CCTSI Research Ethics Conference. Thank you all very much. See you next month.
Thank you.